Dear colleagues, the title, How is your trachea? The trachea is the highway to the lungs. And the pressures that we apply to the lungs, they will transfer to the big airways, to the trachea. Now you all know obesity is still on the rise. Incidence is now about 40% in European populations. We're all bound to face these patients during our clinical practice, inevitably. Another issue is ventilating. The NAVAT stands for navigating towards anesthesia targets. And we know that airway pressure and ventilation during positive pressure ventilation in class 3 obesity patients can be problematic. And what are safe airway pressures? What safe targets should we aim for? Now we do have some guidelines, and Marcos already showed some of us. Lung protective ventilation is used in non-obese and in obese patients. And the aim, of course, is we try to reduce post-operative pulmonary complications by focusing on the pathophysiological pathways in these post-operative pulmonary complications. And they involve, guess what? High pressures, barotrauma, volutrauma, atelectotrauma. The cyclic opening and closing of the alveoli is very bad because it will cause some type of inflammation, and as Marcos clearly demonstrated, it'll cause damage to the extracellular matrix. And lungs are fantastic organs, they are elastic. Lung protective ventilation in non-obese, we're quite aware of that, but there are some, and this slide sums up what we know about lung protective ventilation in surgical obese patients. I'm not going to talk about IRDS, ICU patients, surgical patients. The low tidal volumes, start with low PEEP. Monitor, and this I noticed there are quite a lot of young colleagues today, and I like to thank them for being here. We monitor airway pressures, but maybe we should start thinking about monitoring dynamic compliance, driving pressures, plateau pressures. We know that in obese patients, we should try to keep those plateau pressures below 22. If you're focusing on driving pressures, keep them below 18 centimeters of water. Alveolar, one of the problems with obese patients is atelectasis. And one solution for atelectasis is alveolar recruitment maneuvers. So when should we perform them? After disconnections, or whenever the saturation of the patient is consistently around 94% or lower. If saturation drops below 92%, first prioritize increasing the inspired oxygen concentration, increase your PEEP, over the increasement of PEEP. If it still persists, then you go to an alveolar recruitment maneuver using the machine. Remember that, use the machine. And of course, with the lowest effective pressure for the shortest effective time, the fewest numbers breaths. Marcos already showed us some details on kinetic. Kinetic energy can cause damage to this precious tissue. And then you go for an increase in PEEP. Driving pressure is something that we already know, but maybe we should start to get familiar with this concept of transpulmonary pressure. And in this slide, I'm trying to illustrate. On the left, we have a normal weight patient. On the right, a class 3 obese patient. And you all know the formula, driving pressure, that's your plateau minus your PEEP. But when it comes to transpulmonary pressure, you can calculate it at the end of inspiration or at the end of your expiration. These are the formula that are currently being used. And inspiratory, that's your plateau minus your intrapleural pressure, and expiratory, that's your total PEEP minus your intrapleural pressure. And that's what the physiologist likes to call, that's the PEEP that your alveoli, your lung will feel. So if we look at the illustration, both patients have 20 centimeters water PEEP. They have a plateau of 30. On the obese patient, intrapleural pressure is 4, in the non-obese 4, in the obese 12. That gives you that if you calculate end inspiratory and and expiratory transpulmonary pressure, you will notice that in the non-obese patient, exactly the same figures, but look at the transpulmonary pressure. Now, for your information, any transpulmonary pressure higher than 20 will cause overdistension of the alveoli. And the extracellular matrix will be damaged, and we're off for a cascade of inflammation and a lot of trouble. And I think this slide is from Jedi Sproom on the issue of how high can we tolerate pressures in obese patients. Jedi Sproom already mentioned we all use 40 centimeters of water, and the obese, maybe we can go a bit higher, 50 centimeters of water. And of course, this is based on that concept of transpulmonary pressure. Obese patients have higher intrapleural pressures, and probably that's one of the reasons why we can tolerate a bit higher pressures in obese patients. And another illustration, in a patient with obesity, it's almost like the increased weight even protects our alveoli against the problem of overdistension. Because that's definitely something that we need to avoid. And you will notice this higher intrapleural pressure maybe even protect the alveoli of these obese patients. And that's probably the reason why Gerard Sproul also advised maybe we can go a bit higher. Now, this concept of transpulmonary pressure, you have to realize that it has a regional distribution. This is an obese patient in a supine position, ventilated with 0 PEEP and with a with a plateau pressure of 50 centimeters of water. And you will notice the light blue areas are aerated parts of the lung, the dark blue areas are atelectic, and the alveoli, the white circles, and the red cylinders are the perfusions of these alveoli. And you will notice the apical part of the lung, the mid zone, but have a look at the posterobasal parts of the lung. And you will notice that even end expiratory and end inspiratory, these transpulmonary pressures are negative. The alveoli is even like in a vacuum chamber. And this is important information, and I'll tell you why. A lot of patients now undergo surgery, robot-assisted surgery in the steep Trendelenburg head-down position. These dark blue areas will even increase. And I noticed many anesthesiologists run into trouble when you try to ventilate obese patients in a pressure-controlled mode, for instance, 15, let's even take 20 centimeters of water. Suddenly, you cannot ventilate the patient. What's going on? And that's the reason. Those basopostural areas are atelectic. They are flat, like this balloon. And we all know if you want to open these alveoli, you need high pressure. So open them, and you need a lot of pressure. And once you've opened them, you have to keep them open. How should you keep them open? Listen carefully. PEEP. How much PEEP? To be honest, we don't know. We don't know. What about those recruitment maneuvers? Because recruitment maneuvers, you will need to apply higher pressure. So, how to perform when and how to perform recruitment maneuvers. Now, for our younger colleagues in the room, let me remind you, a recruitment maneuver, these are the 3 conditions that you need to fulfill. Adequate depth of anesthesia, hemodynamic stable patients, and no relative or absolute contraindications. In RDS patients, there are a number of patients that are not fit for recruitment maneuvers. In our surgical patients, sums up. These are the patients who probably should not do a recruitment maneuver. And of course, patients with bad ventricular function. Be careful with your recruitment maneuvers. Maybe you should lower your pressures, and maybe you should even give some inotropic support. Bear that in mind. Is it safe to perform these high-pressure alveolar recruitment maneuvers? To open an atelectic alveoli, you need a transpulmonary pressure of at least 30. Pneumothorax is at a risk? Yes, but you have to exceed a transpulmonary pressure of 60 centimeters of water. If I translate that to an airway pressure, 75 to 90 centimeters of water, then you run into trouble. On one condition, my dear colleagues, recruitment maneuvers use a pressure-controlled mode and stepwise increments in PEEP. Go low and slow. And of course, using the lowest plateau and shortest effective times. Be gentle with your alveoli. When should we perform recruitment maneuvers? That's a big debate. But let me give you some guidelines. After induction, you can perform them. Before you start your surgery, before you install your pneumoperitoneum, and of course, any sustained decline in compliance or hypoxemia. These are the indications for recruitment maneuvers. And maybe at the end of surgery, should we perform a recruitment maneuver? Well, bear in mind, maybe don't use suck. We did all our best to open the lungs. Don't vacuum them empty with sucking in the endotracheal tube. Avoid zero end expiratory pressure before extubation. And I'll show you some details. We are very good at maintaining oxygenation during surgery. And once we extubate the patient, all our efforts are lost. So maybe we should continue this process of protective ventilation after extubation. Let me show you quickly this slide. There are even studies that don't do any recruitment maneuvers. Outcome is the same. So maybe I'm a con. How to perform recruitment maneuvers? Well, let me show you what you shouldn't use. Don't use the technique of back squeezing. You know, you APL valve, you go to manual, APL valve, 40 centimeters water, squeeze that bag as hard as you can. Well, let me show you what happens when you go back to your ventilation mode. Have a look at the airway pressures. When you change your valve, your PEEP goes to zero. And again, your alveoli will collapse like a nice souffle. So you have to avoid this. If you don't avoid this, you will have that cyclic opening and closing. And please show some respect for the lungs. Don't treat them like you're playing an accordion. Open, close. You'll have electrotrauma. Again, for our young colleagues, this is an example, and Marcos already also showed it. But what I would like to point out is the fact that during that stepwise decrease with your PEEP, pay attention to the compliance, because when the compliance starts dropping, that's the collapse point. Look at the figure at your machine, and the best PEEP, the optimal PEEP, is probably 2 centimeters above this collapse point. Can we individualize PEEP? Yes, we can, but you need some technical equipment for that. One of the techniques is using electrical impedance tomography, where you can visualize atelectic zones. And of course, if we look on the right, we're using low PEEP. We have a lot of atelectasis. We increase the PEEP, atelectasis go down. Ooh, this is perfect. But if we keep on increasing PEEP, we have the problem of over-distension. Remember, you'll damage the alveoli. So this is the technique that you can use to individualize PEEP. Let me show you the results of these studies. Amazingly, to open that alveoli, you need 18 centimeters of water, with, of course, improvement. But look what happens. This high PEEP will also cause hemodynamic instability. And another frustrating part, you extubate the patient, all our nice work goes, it melts like snow before the sun. This is another study using transpulmonary pressure, and you'll notice that again, before capnopneumoperitoneum 17, during capnopneumoperitoneum you need 24 centimeters of PEEP to open the lung and keep it open. Again, big frustration. Intraoperative, postoperative oxygenation did not differ. Another simple technique, look at the inflation pressure of the surgeon and go 2 centimeters above that. That's a nice shortcut. Now, bear in mind, obese patients have a higher risk for cancers. So it is not unusual to see obese men and obese women undergoing robot-assisted laparoscopic procedures in steep Trendelenburg. What should we do to keep the lung open? Yes, recruitment maneuvers and PEEP. And let me focus on these high BMI groups. Look at the amounts of PEEP that you need to keep the lung open. Another nice thing about this study is So you perform recruitment maneuvers after intubation, before insufflation, and at the moment of in the steep Trendelenburg position. Maybe that's also a good advice if you have difficulties in ventilating these patients. Use recruitment maneuvers. There is one thing I've neglected during this entire talk. That's the trachea. Because for positive pressure ventilation, we need to intubate the trachea. We put in an endotracheal tube. We inflate the cuff, and we're very gentle, of course. We'll inflate the cuff with 25 centimeters of water, because 30 centimeters of water, you'll have ischemia of the mucosa, and we're into a lot of trouble. Infraglottic stenosis afterwards, sore throat. But look what happens. And this is a study after peritoneal insufflation. These higher airway pressures will also be transferred to the cuff pressure. And cuff pressures go up to almost 36 centimeters of water. We're in the danger zone. We're in the danger zone. Huh? We're at risk for complications. We're also at risk. We need to go to maybe 50 centimeters of water. We will have cuff leaks. How to solve this problem? Go and have lunch, come back, and listen to the talk of my dear colleague Jan Mulier. Thank you very much.